Wonderful, thank you. So if it's okay, I'm going to sit here and moderate. It's kind of more comfortable and more discussion-based. So a number of you touched on this idea of, what communities want and need, and I think it's kind of what do you think communities want and need, and then what do you hear from communities when they're actually in them. And so I think following up on that discussion, wanting to talk a little bit more about as you approach communities and partner with them to do this work, is that always aligning with the current evidence base? And if not, kind of what are the gaps that you've seen in terms of really trying to take evidence-based practices and partner with communities to implement them? And kind of we'll start with you, Dr. Oscar Sanchez, and kind of go in whatever order you'd like after that.
So I'm sorry, I was trying to remember Dr. Hawkins' name. So I didn't remember. So if I heard your question, that it was about what communities want and is it evidence-based? And I guess it comes back this idea of principles versus programs that we were talking about yesterday. And so definitely I would say that taking the evidence about positive youth development and taking that principle first and then asking then how does that apply in the specific community, I think has been what's driven a lot of our work.
One of the great experiences I had was to work with Tom Farley. I think he's in Philadelphia right now. And he always did pay attention to the data and always did pay attention to some of the very important trends that were happening. I think right now he's focusing on obesity, on alcohol, and on tobacco. And he's always been very single-minded in that way. So I think that that's a nice start point. I think from there, that low agency piece is very important for me, especially related to the evidence base. I think that I heard the programs and the principles side of it there, and I think that's an interesting thing. I see the workshop was kind of setting up this juxtaposition between these two different pieces here, and it was very interesting. I think that you can certainly start from that data on that level, but then at some point you have to look at what the makeup of that community is. I mean, you have to look at who's there and have those conversations and really pay attention to what they're saying. I think as Manuel said, there's different ways to do that. The coalition model for us has been very effective because they're starting from their drive and from what they're seeing in their community. Matching that up with different trends and standards that we're seeing nationally, it allows us to do training and technical assistance to go from there. I think there are a lot of ways to get that community input, though.
So I would just say our community is not only the families and teens, but also the providers, and because they're the ones who are going to be delivering these services, whether it's pediatricians or other clinicians. And so we have to try and respond to their needs as well. So families and even teens really want behavioral health services, and families really want parent engagement, and the more services, the better. Providers, like providers everywhere, are really they're facing competing priorities and 15-minute visits and how do we expect them to provide these services? So we have to try and figure out how to tweak the system and increase its capacity so that those services can be available. And so that's why we're trying to look at different models that maybe don't rely on pediatricians but are in pediatric primary care, which is a non-stigmatized space, because really most of the families and kids are never going to darken the door of a specialty treatment program because of the stigmatized kind of feel and ideas that they have. So moving things into a space where they feel comfortable and it feels like a positive experience even when we're dealing with difficult issues. So that's what we're trying to do.
I'm not sure I exactly know the answer to your question, but I would say two things. One is, having worked with juvenile justice, primary care, public health, child welfare, I've never found them to ask me for a program or a practice. they ask for help with a problem. They have goals. So, we often are the people who have programs and practices, and oftentimes we have one of them or two of them or a small number. And so I've never had anyone actually say, we want what you do. Instead, they say, we have this problem, can you help us? And I would just say that to me has been both a challenge and also, I'd say, a blessing. Because it says if we're really going to help the community, it isn't that they necessarily want what we do well. They want to deal with a problem they're not doing well with. And I think that's the first step in a collaboration. And the second thing I learned from Kelly Kelleher, who was here, and John Campo, which is help them first and study and get data and bring evidence second or later. And I think those are the two principles I guess I've used to try to help pull this together, even though I realize there's a great divide.
I'm not sure what to say. Having a program is an interesting place to come from, because there are people who actually have come to us and say, we want your program. But they want the program because they think they have a problem and they think they have a way of seeing it. What I've seen over the years is that prevention is really a challenging issue to try to define for people. Most people can understand treatment very clearly because then there is a problem. Prevention, on the other hand, is very difficult for most people to get a grasp around and see the benefit from. And so in many ways, we keep reinventing the need for prevention, and people may not see the need for prevention ever. That's why there's the two large projects that are out there, Communities That Care and the Prosper Project. Both have a great role to play because they do figure out how to get those people in the communities to understand that the need and that the promise of prevention can provide. And they also ultimately come to understand that even though it's not cheap, it does cost an awful lot less.
Great, thanks. And I'm going to go off script with moderators' prerogative, so stick with me here. So you raise a really interesting point, because I think one of the things that we've seen in our work is the conversation that needs to happen around the value of prevention and almost a selling and a marketing of prevention. And so I guess I'd love to kind of get the panelists' thoughts on that. Do you need to sell prevention to communities, or how that kind of conversation goes, or do they instantly get what you're trying to do and the impact it's going to have in their community?
Well, let me just start. A couple of years ago, I started working with some pediatricians out of Baltimore, and we started talking about what prevention would look like in a pediatrician's office. The pediatricians themselves had a very difficult time understanding what prevention meant. They wanted to do the same sort of testing that you do in Kaiser Permanente. What's the name of it starts with a C. The craft. They wanted to do the craft. And I'm thinking, well, if you want to do the craft, you're never going to understand, because you're going to use the craft data to identify people who are actually beyond primary prevention. You're going to have to use the craft to identify people who actually need treatment. And so it took a while for us to come to a resolution about what prevention meant in a pediatrician's environment. And it was challenging. I think they finally got it, but I'm not sure.
I would say that it hasn't been that hard. I think the question is what's your leading question? And you can go in and say, well, what are the problems that this community is facing? Or you can say, like I said, what is it that kids in this community need in order to have meaningful, productive lives? And all of a sudden that changes the conversation. And they buy into that. And they can contribute to that. And I don't think they have trouble understanding that once it's the question that we start off with.
So I think that's a great point. I think you wonder if it is necessary. But on the other hand, I would say evidence-based medicine has been around for 50 years. And the physicians have gotten it down pat. the black and white world of what works and what doesn't work, and prevention is kind of catching up to that. I think that when it comes to the value of prevention, it's starting to come from the world of healthcare. If you believe it or not, the actuarials have figured out that if you pay a person $350 to go get their clinical preventive services, I know Blue Cross Blue Shield is doing that right now. So whoever they have plugging the numbers over at Blue Cross Blue Shield has it figured out from that angle. I figure we need to get some actuarials over in the prevention world so we can start measuring it out. And you know, some parts of it have gotten to some numbers, but I think if we're going to ask CMS to pay for this, and if we're going to ask for insurance to pay for this, we're going to have to determine what those numbers are.
So I guess I have the great good fortune to be both an employee and a member of an organization whose model is built on prevention. So that's what it's all about. And I mean, it's about that from the bottom line perspective, but it's also about that. I think as a member of Kaiser Permanente, you just expect it. So we have huge population health management programs in hypertension, in diabetes control, in weight management, in exercise, and now we have really, over the past 5 years, I've seen a lot of very innovative work being done in terms of addressing social determinants of health. So community connectors, people who are connecting patients who have challenges with transportation or food or paying their energy bills, connecting them to those services in the community, and those are obviously things that feed into the types of problems that we're talking about today. We're beginning to do pilot work on ACEs, adverse childhood experiences, both in OBGYN and also in pediatrics, so trying to address those. And so all of those are tied together. So I think, and of course those are tied to, you know, the bottom line, which leadership certainly is aware of. So I think our community as a whole expects that. That's the norm.
I think it's interesting, and I think a lot of conversation about the shifting role of healthcare in particular. And you know, I kind of joke, is that a trend that I just see because I'm in, you know, progressive Southern California? I think the conversations we're in are how does healthcare become more responsive to those broader needs, the kind of conversation around social determinants. So I was just going to kind of sticking with that, but I'm sure you're going to respond to kind of how you see that playing out in the communities that you're working in.
I'll just add one comment about the prevention idea. I guess I think of most of the time when I'm working with a community, it's hard to distinguish between treatment or intervention and prevention. I mean, you have a 5-year-old who's doing something, and mostly you're working with a caregiver and a child to prevent perhaps worse outcomes later. So I think those kind of get more blurred on the clinical side than maybe on a research side or policy side. But the other thing I would say is, to the extent that one has to describe preventive benefit, at least my experience is, since it's delayed and therefore not often experienced and not paid for by the system. I mean, the child welfare system pays for certain things that are really failures of other systems and vice versa. So I would just say it's harder, perhaps, at least in my experience, to make prevention meaningful and marketable unless one actually can speak to, you know, what actual data or what particular types of adverse outcomes this really does prevent. And then I think it's an easier conversation.
Yeah, we'll go to questions now. I was at a conversation recently with a staff person from APHA, kind of talked about, you know, if we're successful in prevention, nothing happens, you know, and how do you kind of capture that in all the ways we need to capture it. So with that, I'm going to open it up for questions.
Actually, he's first. Thank you. It's kind of you. Kelly Kelleher. So just the two questions. I think as prevention researchers, though, we have two obligations that we haven't fulfilled. One is to say, when we're successful with prevention, we need to start saying what Tony said yesterday, which is that children thrive. And we have to quantify that more effectively and show how children will be successful, productive members of society and engage with their communities and all the relationship things. So we have to I almost feel like we have to quash that kind of conversation if we can, but I don't, you know, however we go forward in a positive light. The second and more important thing for a policy perspective is everybody right away turned to, well, how do we pay for that and sell it? And I think that's absolutely appropriate. But our benefits, if you try to prevent diabetes in an adult population or heart disease recurrence or anything like that, you can see a benefit within a year. And all our contracts are annual health insurance contracts. We have to convince CMS and insurers that pediatric care is a long-term process. Community development is a long-term process. Family engagement is a long-term process. And these are results that have 5 and 10 and 15-year outcomes. And so contracts and rewards have to be different. But while we're saying that, we should also be studying what are the short-term outcomes. So, what is the right length of time for you as prevention people in the community that we should show benefit for? I don't know.
So one of my favorite authors on this, of course, is Neil Halfin.
Yeah.
And Life Trajectory. I think we need to be very careful with that on a national level and what that means, because it's, as you said, it's a very, very tricky thing going from those across the life term and just what happens in the course of the first 15 years. You know, I have to say I do like to think nationally, and it's why I'm working where I'm working. But I really do have to hearken back to this community by community. What if there's something which brings communities together? I mean, when we do trainings, some of the effective trainings are coalitions talking to coalitions, the people that are doing the work. You know, I've done work in the past where we've linked communities by state. Region 4 and 6 are in awful shape. Region 5 is bad in the cities, health equity. So I don't know the answer to your question, but I do think it's a very important question, and how we can be more planful around the lives of our children.
So I would just say, from a research perspective and trying to make the case to leadership in our system, one thing that's been great is the ACA covering kids until they're 26, and so you know, the system has an interest in keeping these kids healthy because they're going to be members now and they want them. And then the other thing I think is the growing information around comorbidity. So kids with behavioral health problems having physical health problems that translate into cost. And trying to make that connection and show how preventing some of the behavioral health stuff can also lessen or ameliorate some of the physical problems.
Thank you. Great discussion, very generative, and I think also for the next segment, stage setting. So one of the themes yesterday and on the panel is we need to think way bigger than programs and principles and practices. And I'm going to pick up a quote you, Stacy, to pick up on part of the question, or one of the questions concerning how we do that. What's the best way to do that? You said providers are part of the community. Yes. And then you went on to talk about how we need to, quote unquote, tweak the system. So we know the bigger perspective has to be about thinking about social determinants and, generally speaking, community perspective, but also about systems. So woven into the lives of all of the people in all of these communities are those local systems, a public education system, the healthcare system, and the social service systems. You kind of hinted at a big question I think we need to answer, and is how do we change these systems? Maybe transformation is too grand, but tweaking or more, how do we change the systems that are woven into the lives of the people we want to serve in these communities?
Well, I'll start.
Bill.
Well, I presume you actually have the answer, so by asking the question. One of the challenges
I wish.
I'm looking back 40 years, and I'm trying to look ahead 10 years. And I realize that the things we have today, I'd never envisioned 40 years ago. And I'm having a very difficult time figuring out what 10 years from now the systems are going to look like. I mean, what kind of car are you going to drive, or will you have a car, or will there be cars? Those are the systems that we engage in are so vast but so malleable by the technology that influences us, that if we try to build a system today, in 10 years people will look and say, why did you spend all that time trying to do that? If you have an answer to it, Dick, I'm going to invite you to say something.
I think it would be a productive line of conversation. I'm guessing a lot of people here have a lot of ideas. We already heard a few. Stacy, where are you going?
Well, I was going to say something that we are doing, and someone mentioned community benefit and what not-for-profit hospitals and systems, health plans need to do. So we work very closely with a number of school-based health centers in our counties and our region, also with the safety net FQHC systems, because our membership is very porous. So a lot of people are Kaiser members, and then they're not Kaiser members, and then they're Kaiser members again. And we have a stake in keeping everyone healthy, regardless of what their coverage is right now. So trying to integrate those systems, whether it's social service, education, health plans, and so forth. I mean, I think that's a real path forward where we all have sort of a prevention focus. And I think there are a lot of examples of where that's actually happening.
So if I could just build on that, I think people with a vision can start collaborating and building an entire system of things. Kaiser Permanente, when we live in Southern California, it wasn't quite the same, but it was still there. As long as the Affordable Care Act isn't entirely repealed,
Decimated.
There's still hope that kind of thing can, but I don't know that it can be engineered, is my concern.
That's a good point of focus. In deference to the other people here, just saying that is a point of focus that I think would be very productive, what you suggested. The ACA is driving changes in the healthcare system. There are opportunities there. How do we seize those opportunities? But and speaking of community benefit.
Well, no, actually, so for me, and because I'm here, I want to have the opportunity to say this and see what people think. So this all started with evidence-based programs, practices, principles, and then we went all the way to social determinants of health. And so what we're missing is really the environmental strategies that nobody's talking about, and that is what changed tobacco. It was basically you couldn't smoke inside anymore, you had to be 18 and show an ID, social norms changed, you became a pariah, you couldn't smoke in your own house without your wife wanting to divorce you. And so the question is, we're all talking about the health system and it's individual behaviorally based or social determinants of health over here, and we can't miss the public health aspect of this and the types of strategies that get us population level outcomes, and that's not being talked about at all here, and I'm not part of this group. And so I just want to say we're missing a very big piece of this if we don't look at, 21 drinking age. Look at what really did change the rates of tobacco and alcohol use in this country. So anyway, it's just my soapbox, but I'd like someone to respond to that, because if you leave here and you go from programs to social determinants of health, you're missing the whole public health part of this that's population-based. My 2 cents.
Is anyone working on environmental strategies as part of their work with communities?
So since Sue's a colleague of mine, I'm going to take it as my hand got slapped or something like that. But I think I've been implying it, but haven't really spoken to it. I think that when we talk about the different pieces here, one of my favorite sayings is culture eats strategy for breakfast, if you remember that. And I think when we look at environmental strategies, we're looking at that cultural piece when your kids yell at you from the back seat to buckle your seatbelt, which is a big difference than 20 years ago. I think that some of that can be prompted through the ACA. Community benefit's a big deal, but the hospitals are spending $800 million on community benefit last year alone. $800 million. The law says you have to use public health. I guarantee a lot of them went out and hired MPHs within their own shops and used them. I think that there's promise there, but I think we're scratching the surface when it comes to these kinds of things. And I would also argue on something like the patient-centered medical home model, which prompts practices that want that recognition, if they want that recognition, to engage with the community. It tries to encourage them, but now it's under attack, as really doesn't improve quality of care. I think that we're taking baby steps right now, and I think that if we pay attention to those environmental pieces there, we can kind of help move them along. We're putting those steps against something larger.
So I know you were next, but do you mind if, since they've been standing, we go back and forth? Is that okay?
Oh, yeah.
Yeah.
You can go ahead.
Okay, go ahead.
That's fine either way. So my name Leslie Walker. I kind of think about things differently, so I'm trying to figure out how I can say this so it makes some sense. You know, when we think about we're all in this world, we each of us have decades, or a century or so. We get to share the world together, and then we move on. You know, right now, we have these names. We have health disparities. We have social determinants of health. We have ACEs. All trying to describe how people live and why they live that way and what happened to get them there. And then we talk about prevention, and we talk about trying to help people prevent and health. And so we don't actually know, we don't say, and we don't have evidence to examine what does it mean to be healthy? What does it actually mean to have an adolescent be healthy, a young adult be healthy? What does it mean? What is prevention? I mean, even though you talk about the definition, but is prevention, a lot of times we're talking right now, prevention is the absence of bad things, or is prevention the absence of barriers that stop people from thriving? I mean, my goal is so that one day before I leave this earth, I can hear the perfect aria, or I can go and drink water anywhere because it's clean. I can, have a family that I know that they won't get this particular cancer because the people that are alive right now that can make these inventions that can change things are able to thrive and get there. I mean, that's my overall goal. And most of that doesn't happen as a physician in my office. It happens out in the world. So I have to be a part of that world. So I'm curious, we get kind of stuck in the little areas that we are, but thinking bigger. So what do you think the drive for prevention should be? I mean, should we really begin to really work and hone in what we expect out of health and what we expect out of prevention? So.
I feel like I carry on too much. One of my go-to is something I like, and that's the World Health Organization's definition of health equity: goodness and fairness. And I think that is what you're speaking to right now, and that's been a real focus on a lot of the work that I've done. Goodness and fairness is kind of health equity.
My name is Eve Rader.
Sorry,
I didn't realize. Go ahead.
I'd like to be sensitive. A lot of it is local, and in different communities, that might be different things that they feel their kids need. Because definitely in the community we work with, they definitely see that there's inequities in education and all the effects that has. But they want to, in the latest work we've done, they want to define health as having supportive peer relationships, having supportive adult relationships, and those are the most important things to them. And so let the community itself decide what are the things that we want to work towards.
My name is Eve Rader, and I'm at the National Center for Complementary and Integrative Health, and was previously at NIDA for 15 years. And I just want to say there's been some discussion about what's the evidence and what's the cost benefit, and we need information on this. And I just want to say that we have a lot of information, and I think it needs to be used better, because we do know that you can intervene early in children's lives and in vulnerable children's lives who are very high risk and have an impact on their life trajectories in many different ways, both reducing problems as well as very positive outcomes, and that these interventions have an effect on a broad array of behaviors
And there is cost-benefit information on some of these, and the state of Washington has been documenting it for many years. And we also have evidence that you can implement these programs in systems where communities make choices about them, what they're doing in their communities, and that they can have an impact over time, not just on substance abuse, but on delinquency and positive behavior. So I think when people say there's no evidence or we need the evidence, I think there's a lot of evidence there, and we need to figure out how to implement these programs and systems. And I think a lot of the programs, maybe not every single one, were developed with communities involved in them. So I think that's important to say also.
So I would just respond and say you're absolutely right, and we try and do that as much as possible, but I think there is such a disconnect, which everyone here knows, between the research base and the evidence on cost effectiveness and cost offset and so forth, and the people who are making the decisions in the communities, and how to message that in a way that policymakers and community members understand it and can embrace it and put it into and implement it. So it's just a challenge that, never-ending challenge.
So my name is Jose Shapasnik from the University of Miami. So for many years I've worked with Hispanic immigrant families in poor neighborhoods. And like Manuel, families have never been at a loss to say what is it they want for their children. And so when you ask families what they want for their children, it's somewhat predictable what they will say. I don't want my girls to get pregnant. I want my child to finish school. I want my child to be successful. I don't want my child to get involved in delinquency or drug use. So never, in my experience, have families been at a loss to say, what do we want for our children? When we ask that question that way, they always know. But it does connect to the social determinants. So we have programs that can help that particular family to prevent those outcomes with their children, but we're really lacking in programs that can help that community, that population of families, to prevent those outcomes as a population.
I guess what I have to say is very similar to that too. I'm Martell, I'm from the Root Cause Coalition. And I think a lot about the question of like what communities want versus what they need, and then even about that question itself. I like the first research, like my involvement in research started with community-based participatory research. And so I think a lot about how can communities have true decision-making power in this research from the very beginning all the way to the end, and how it is like discussed and given back to the communities. And something I just wanted to name that I thought was really interesting is I was really impressed yesterday by Pastor Harris and his work, and how involved the voices of the community were at the decision-making table in his work, and also with the work that Dr. Osco Sanchez is doing, and how both of those are focused on violence prevention instead of like substance abuse prevention. I thought that was just really interesting, and I think speaks a lot to sort of addressing what are the root causes of why these adolescents are becoming involved in these negative health disrupting behaviors.
Patrick Tolan, University of Virginia. I wanted to bring education system back into the conversation. Bill, you said you started out in the schools because that's where the kids were, and that's where you could get access to them. And Mark's been doing work trying to bring mental health into a school setting as a part of the way. If they do good education, we'll get mental health services kind of idea. I think that's a decent summary. So there's a different angle, which maybe we could talk about, and we've been trying to work in this area, and it comes out of interest in this idea of what does a healthy kid look like. And that's positive youth development and what that looks like, and that So working on the idea that a part of education is how do we produce healthy people, not how do we make sure people read well or do math well. Those are important, but those are part of being healthy people. And so that education includes things like, as we've now recognized, the importance of self-control, the importance of emotional literacy, the importance of understanding how to manage your body and your health over a lifespan. One of my colleagues says we can no longer outsource our health care. It's something we have to manage ourselves. So starting to bring that in, and I think there's some recognition going on in foundations and in policy levels that education and health are not two sectors, they're intimately tied. So that maybe is another piece to bring here, is that we, when people are talking about these ideas of both this big idea of health equity and this big idea of social determinants of health, I think one has to start to sort of pay attention to how things like how we educate kids and opportunities to educate kids can have big effects on what our healthcare costs and what the health of the nation are. And similarly, how pediatricians think about social emotional development as part of health and other people has a big determinant on how well kids do in school.
So I don't disagree with what you say, but I think that we also need to, there's a key problem and it really gets to the social determinants of health. So I really don't think that poor Latino kids need sex education, they don't need conflict resolution. They need equality in education so that they can then be competitive in our world. And that's lacking severely. And so the quality that the kids get, and so I'm always resistant to doing things during school time because I want my kids to learn how to do math and science and read and learn the fine arts. All that other part is part of educación and learning all the character and all of that. That's important, but I think we can't forget the inequalities in our educational system that then have long-term impact.
Well, I thought Pat brought some things together very nicely, but there's been a lot of discussion that seems to me to say, well, these all seem like disparate things, and how do they all fit together? But you know, the IOM report on prevention in 2009 argued that we have the science to ensure that virtually every young person arrives at adulthood with the skills, interests, values, and health habits they need to live a productive life in caring relationships with other people. And I think that that's a vision of people who are, you know, broadly ready for the world and have the social skills, have the cognitive skills, have the knowledge, and so on. And I think that that's a vision that we need. And I wasn't exactly sure whether I agreed with you or not, but you raised the issue of what happened with tobacco control. And you know, when I speak in rooms of this size, I usually say, well, 40 years ago, this room would have been full of cigarette smoke, and I would have been one of the people smoking. And we changed our society massively. But I think that one of the things that I think can simplify what we need to do here is to understand that the common conditions that produce all of these different problems are essentially stressful, coercive social relationships in families and schools. I mean, there are other things, but those are the two major drivers, right? So, you know, it seems like tobacco control is an easy problem because we can, you know whether or not people are smoking, we can assess that, we can see if it's going down and so on. But then when we turn to all these other problems, we say, well, we got to look at the rate of drug abuse, we got to look at the rate of depression, we got to look at criminal justice, and they're all different systems and so on. But if we understand that what we fundamentally need are nurturing families and schools, that is, families and schools which minimize toxic social interactions and richly reinforce all of the kind of pro-social behavior we want, which includes reading and math and getting along with others and so on, then the public health requirement is that we change the prevalence of nurturing families and schools. And I think all of the programs we've talked about and all of the policies we've talked about are relevant to that. And when I say policies, all of the issues having to do with discrimination and having to do with poverty are major, larger contextual factors that influence the quality of those environments. So I think that the public health goal needs to be to increase the prevalence of nurturing families and schools using both distal and proximal influences on those.
Can I make an interesting, well, a comment that it's not in direct response to Tony's question, but one of the things that I've noticed changing in schools over the last years is in the 1980s and 1990s, prevention actually was increasing in its importance. And then No Child Left Behind came along and it reversed course. And what became the driving force between of No Child Left Behind became standardized testing. Everybody was tested every year. Schools were judged by whether or not they were succeeding or failing. And that pushed prevention aside in many ways. Funding, the anti-drug schools, thank you, disappeared. So there's no funding any longer for it. And when there's no funding, there's no priority. But I think part of what we need to focus on is how we use data to drive those policies. Because No Child Left Behind now seems to be struggling because the policy itself has struggled. But at the same time, we need to find a way of using data to help raise the awareness. I think part of what helped tobacco control and drinking were data that showed that these broad social policies had an effect. If there wouldn't have been the data to support it, it wouldn't have mattered how good we were. It wouldn't have had the support and the continuing support, because those things haven't changed. Once those changes took place, they seem to stick. And so I think part of it is environmental, but part of it really is getting access to something that speaks to people so clearly that they say this is the way we need to go forward.
Joyce.
And you were next.
Thanks. So I'm Buzz Land. I'm a general pediatrician, and I work for the American Board of Pediatrics. And I'll just be critical of my own profession for a minute in the role in this. I think that that until we value prevention more, we're not going to be able to accomplish it, at least again from the role of the medical field. I think, Stacy, you pointed out the good points of Kaiser, but I think that most hospitals and most medical systems and institutions thrive because of taking care of sick people and testing to see whether people are sick. And they don't thrive because of preventing people from getting sick. And until that's valued more, it's going to be hard to get these wonderful ideas that are emotionally making me excited today. And it's not going to work well. So, thanks.
Yeah, I wanted to bring up, again, I think some of this conversation takes us towards and I guess my name is Joyce Sebian, also SAMHSA, takes us towards the work in implementation science, because I think the bridge between some of what we're talking about and the environmental strategies and the public health piece is work such as collective impact. That it's essentially a public health model, or communities that care, other prosper. I think it's that getting to that framework where you have an umbrella around that is a public health approach, and that includes then environmental strategies, it includes evidence-based practices, it includes all the social determinants, because the sectors that represent those different housing, labor, employment, business, they are all at the table when you're using a solid public health approach that creates a shared vision in a community. Then everybody can take a look and see, what hat am I wearing to create a good place for families to work and be able to go to school and visit their kids or have PTA meetings or whatever. I think it is a bridge, and we need to be thinking about that. And in the context, where do our EBPs and community adaptations fit? So that was one piece I wanted to bring up. I don't think it has to be, it is complex, but it doesn't have to be framed in a complex way. The other piece is that I think when we use the language of health, people still do not necessarily think about behavioral health, mental health. So I think we're still in a transition phase where we have to be very cognizant to include that language in there. And then I think we are making big headway around the benefits or importance of mental and behavioral health towards academic outcomes. But I think this is an area where we really need some solid messaging, and we really need to help our community players in the different hats that they're wearing translate that, and we need it at a national level. I think that the prevention question is people still don't see the public value in it. And Ohio's doing some great work. I don't understand it well, but it might be worth looking at it, where they're doing a lot of public value propositions, and I think there's a good research base to that, and it seems to be helping move the public towards understanding why some of these strategies are important. And I know in one county, they actually decided to fund, this was a Dennis Embry thing, they funded through tax dollars the good behavior game in the county. So some of that is through, which is unprecedented, and it's through public value types of work. Thank you.
So I want to reinforce what's being said about the environmental systems piece here, and the example I want to bring up is the opioid epidemic that's happening right now, and that's affecting children and families, and no one saw it coming. Maybe some people saw it coming. I think it's like a Trump presidency. I do think that there's data, but I also think there's a sense of urgency, and we don't have time to study it. There has to be something done, and that is the benefit of environmental strategies. And I would say that a lot of them existed before collective impact did. That this has been happening for a while, and I think it's being framed a certain way, which I think is great, but I think that we need to stick with this thing that's been working for some time.
I just wanted to say, I think that your point about changing the conversation around behavioral health is such a huge one. And I've been thinking about your comments about public health and how to take an environmental approach. And I really do think sort of shifting everyone's thoughts about behavioral health and mental health and substance use and addressing stigma is a huge environmental thing that has to happen. I see a tipping point. It seems like people are realizing the connection between physical and mental health, but that stigma is still out there. We see it all the time. I think it's even more so for substance use. People are willing to talk about depression, but they're not really willing to talk about drug or alcohol use. They don't want to touch that. But I see changes happening. I was just in a meeting. Kaiser and the NBA are partnering on health, and now they're pivoting to talk about mental health and youth. And I think that's such a huge opportunity because kids don't listen to anyone except their peers and idols, and to have people like basketball stars or Kendrick Lamar share his experiences with mental health problems, I think will really do a lot toward moving the conversation forward. So.
Yeah, no, I think that's a great point. I'm Mark Atkins. I'm at the University of Illinois at Chicago. I'm going to reflect a little bit on this discussion relative to a meeting I was at 2 weeks ago back here in D.C. that the Robert Wood Johnson Foundation was sponsoring. And it was, if I had a transcript of it, it was almost the exact conversation we're having, but it was about schools, and it was about programs in schools, programs versus practices, right? Sound familiar? So it's a very ironic time, I think, for us, and I'm reflecting now on myself as an academic and a researcher, and I also wanted to comment on Jose's point. I think that there's a moment here, and I think you're touching on it a little bit. I'll use the term paradigm shift. I think as we're thinking about social determinants, it's not going to be another program that's going to affect social determinants. It's a new way of thinking about what we're doing, and I want to just also comment on Pat's point about as we integrate ourselves, it's not only integrating our programs, and David made the comment that people prefer to go to a physician, a primary care's office, to get their mental health taken care of. Well, we found that in schools. Parents, 3 to 1, will prefer to sign their kids up to a program to support their learning as compared to going to a mental health clinic. These are for kids who all have mental health needs, identified mental health needs, behavior problems. 3 to 1 in the inner city I'm talking about. And so I just wanted to leave it on a point of perhaps that's what our discussion can be about. What is the new paradigm? How do we do this? It's not enough to say social determinants are important, let's do it. That's not going to get us anywhere. What's going to get us somewhere is to say, how can we contribute to this? What is it that we can do differently? I think your comment about the ongoing conversation about mental health is important.
Excellent. What a wonderful way to wrap up the session. Please join me in thanking all the panelists. So right before we break, I wanted to give you a little more detail about the groups that we're going to go into. And I think that we are really primed and ready to use our minds here to come up with some real, maybe earth-shaking, Shark Tank-like 1-hour power thinking plans that can change the world. and you know what, I'd say that and it sounds crazy, but actually it doesn't take that many people to make a big change. There's enough people in this room in different areas that if we all could come to some sort of common understanding, we could actually move forward and make a difference. And so I want you to take these groups very seriously. We want, at the end of the hour, for you to have each group should come up with 2 areas that you can come to a common agreement about that you think can help move or change this field. And I think it's kind of fun to put some pressure on and see if we can do that. Some of the groups have, I don't know, 20 people, 30 people in the group, so it'll be fun. But so we have here, if you see, some kind of general guidelines that each group should look at with the lens of the topic of the group. Engaging public and policymakers in prevention, sustainability and funding, research agenda. How do we take things to scale, interventions, programs, principles, system change? How do we take that to scale? Those are kind of loosely how we want you to think about the topic area. And Group 1's topic is responsiveness to community needs and building capacity. Group 2, and that's going to be co-moderated by Deborah Klein Walker, and Jose, and I still can't, Sapasnik. And Group 2, sustainability and funding. Kelly Kelleher and Belinda Sims will be co-moderating that. And Group 3, programs versus principles and innovative methodologies. That seems to be a very popular group. Wilma Peterman Cross and David Hawkins will be co-moderating those groups. But please make sure, if you don't already have a group that you have identified, that you think about going into the sustainability and funding group. And all of them should have the same goal of coming out with a couple of things that we can take back and that the forum can really mull over and see how can we move these things forward. Yes? Yep, that's the other part I need to tell you. At the registration desk, the room numbers for where each of the groups are there. And if you don't remember what group you're in, there's also a list of the groups and what you signed up for earlier. Let me see if I have anything else. So we'll meet back in this room at noon, because there's a little break now, and then after the group discussions, there will be another break, and then we'll come back. And each group should have identified one spokesperson to come back and give us your 2 important things. And I think that's it.
So I would like to highlight this idea that we have of having you come back with only 2 recommendations, because what we found in the past is that there is a laundry list, and then we don't know how to prioritize them. So we will put the onus on you all in the committee to prioritize and come back with the 2 recommendations that you think are most critical to move the field forward.
I'll just quickly mention room 118 is the room next door. Room 114 is right across from the registration desk. And the lecture room is actually on the other side of the building. If you cross the great hall that you entered through to the other side of the building, the lecture room is there. Thank you.